Hey there everybody, and welcome to this video on ethics of professional development, self-care, and supervision. I'm your host, Dr. Elise Snipes. In this video, we're going to start out by reviewing the philosophical ethical principles like beneficence and non-malfeasance, and then explore how the following are ethical imperatives: ongoing counseling skill development, ongoing supervision, and of course, self-care. So let's start out with the ethical principles. There are 5 big ones. Some people will say 7, but there are 5 that everybody agrees on. Non-malfeasance means above all, do no harm. Well, okay, that's setting the bar pretty low there, but we do need to always be checking ourselves for whether we are potentially doing harm. Are we operating outside of our bounds of competence? Are we creating dependencies where people feel like they need to depend on us instead of feeling empowered to run their own lives? Are we imposing our values and beliefs on people instead of respecting their cultural identity? Those are just 3 examples. Beneficence, and this is one we don't talk about near enough, and it's one I'm passionate about, is that we need to not only do no harm, but we also need to help further important interests like research, education, advocacy, and outreach. We still don't know 100% of the time what causes person A to be depressed, or why a particular SSRI works well for person A but not for person B. So we need to continue to identify these gaps in knowledge and promote research. We need to promote education of our colleagues. If we find out about new information, a new study that we read that's kind of groundbreaking, we need to make sure that we disseminate that to our peers. We need to make sure that we are adequately educating new counselors, and we need to make sure that we are providing adequate and far-reaching public education about mental health and mental illness prevention. We also need to do advocacy and outreach to destigmatize mental illness and to encourage people to seek counseling. Autonomy is the next ethical principle. We want to support people's right to choose their counselor, the approaches that are used, and recognize the impact of one's behavior, so our behavior, on the client and vice versa. We want to help our clients, the people that we serve, feel like they are safe and empowered to move forward in their lives, not that they need us to do it. We don't want to create an environment of paternalism. Justice means giving all people what they are due, making sure we are providing every single person the highest quality of treatment. And keeping our promises, that's fidelity. Keeping our promises, including confidentiality. So justice and fidelity often go together because we keep our promises to provide high quality care. But justice means we're making sure that we are not discriminating against people, that we are treating each person with due care. The ABCDE steps in ethical decision making. We need to recognize an ethical issue as a decision or situation that could be damaging to someone or to some group that involves a choice between good and bad, 2 goods, or 2 bads. So yes, it can be an ethical decision if you've got 2 good options. They could do this or this, but which one is the best option? And when we talk about justice and fidelity and beneficence, we want to make sure, even if both options are good, which one is the best for this person at this time. So let's start with A. A is awareness, and there's a lot of stuff that goes under A. We need to become aware that there is an ethical issue. What are the relevant facts of this particular case? What if what facts are not known? Can I learn more about the situation, and if so, how? Do I know enough to make a decision in this case? What individuals and groups have an important stake in the outcome, and are some concerns more important? If so, why? And what are the options that I have in this situation? Have all relevant persons been consulted, and have I identified any creative options? So let's apply those a little bit, because there's a lot of stuff. Many people, most clinicians at some point in their career will be involved in having to make a decision about involuntary commitment. So if you have someone who's in crisis, who is openly expressing suicidal ideation, what are the relevant facts of the case? What do you know for a fact is going on about the person's state of mind, about their plan, about their access to means, about their support systems, all that stuff? What facts do you have? What facts are not known? There is a lot of stuff that happens outside of our clinical setting, outside of our office, that we don't necessarily know. There's a lot of stuff that people don't necessarily tell us. Just because they're in our office and they're sharing some of their deepest, darkest secrets doesn't mean they've shared everything with us. So we need to recognize that we don't know everything. Can I learn more about the situation? If so, how? So in this particular case, the person's in crisis. Can I ask this person more questions? Can I reach out to the emergency contact and get more information about whether there's going to be somebody that can be supportive, and so I can make a better decision about whether this person's safe to leave? Do I know enough to make a decision? Or are you in limbo? What individuals and groups have an important stake in the outcome? Well, in involuntary commitment, you do, because your license is on the line. You could be sued if you make the wrong decision. The person's life is on the line, so they obviously have a huge stake in it. And there are a variety of concerns. In this particular case, they're legal concerns. We have the Tarasoff decision that says if there is imminent danger to an identified person, then we have the obligation to act. So we need to be able to identify whether that danger is actually imminent, whether somebody is venting or whether they actually have an intent to harm themselves, for example, and what steps are the best options to take in this particular situation. What are the best options for acting? Couple other situations that may come up. If you are running a treatment center and somebody comes into group or for their individual and they are just drunker than a skunk on Sunday. I don't know where that saying came from, but it's something my family always used to say. And then they intend to drive home. Well, that's not okay. They are actually breaking the law by intentionally driving when they are demonstrably intoxicated. So that's one of the relevant facts of the case. And so you could argue, are the potential victims identifiable? Do we know that there's going to be a problem? And there can be some argument about that, which is why a lot of agencies will put in their informed consent that if somebody comes to treatment or tries to leave treatment and they are under the influence of a substance and they try to drive, that law enforcement will be called. So they put that out there in the informed consent. But I've been in situations in which the agencies have had a policy that because the person is clearly breaking the law and endangering other people on the road, that making a report to law enforcement if they insist on driving while under the influence is appropriate. So it's important to consult. What is your agency policy? What are the legal ramifications? And what do you need to do? When you report them, if you decide to report them, then that is going to cause some damage, if not a lot of damage, to the rapport between you and that particular person as well, partially because they may end up in jail as a result of it. So you need to consider all of these things. Failure to discharge somebody when they are no longer benefiting from treatment. Maybe they've reached maximal gains at this level of care, or they're just not benefiting from treatment, and you've reached this place where you don't have any other tools to provide, or maybe they're involuntary and they're just not cooperating. So what are the relevant facts in the case? What facts are not known? What can you learn about the situation? And do you know enough to make a decision? If the person doesn't seem to be making progress, it's important to consult with them and get their perspective on the situation. If they've reached maximal gains at that level of care, it's still important to consult with them and talk about this discharge process, not all of a sudden just drop it on them like, hey, seems like you're doing pretty good, so I'm discharging you today. That would throw a lot of people for a loop. But it's also unethical to maintain them in treatment past when they actually need to be there. We need to help them feel empowered to apply the tools that they learn in treatment and move forward in life. And if they need to come back for another episode, fine. But allow them the opportunity to grow and solidify those tools. And another thing that might come up, especially if you work in an agency that is funded by the state and or Medicaid, sometimes there are priorities that are set by your funder for treatment. For example, people who are IV drug users, people who are HIV or AIDS positive, and people who are pregnant. All three of those, when I worked there, probably still in Florida, those were treatment priorities. So yes, we had a wait list that was 6-7 weeks long, but if somebody needed treatment and they were in one of those 3 priority categories, they jumped over everybody else in the wait list. Is that ethical? Well, you can argue whether it is or not. However, as an agency, if we lost that funding, if we did not comply with that regulation and we lost that funding, we would shut down, so we wouldn't be serving anybody. Ultimately, that was a policy decision or a caveat that the higher ups at our organization agreed to accept in order to get the funding. So it's important to recognize it sounds awful to put funding above other people in the wait list. However, those people in the wait list are not going to be able to get any treatment if the treatment center shuts down. So these are the things that we need to consider when we're becoming aware. We're just kind of gathering data, getting information at this point. Then we need to look at the benefits and drawbacks of each option. Which option will produce the most good and do the least harm? This is what they call the utilitarian perspective. Which option best respects the rights of all people who have a stake? Now, it's important to recognize you as a clinician and your license and your job may be at stake. Your organization and their ability to keep the doors open and their reputation may be at stake. The individual who is seeking services has a stake in what's going on. So it's important to recognize how all of the things intertwine in order to make the best decision. Which option treats people equally or proportionally? When I was in running a residential treatment facility, and actually I was a clinician there for several years before I was promoted, we would have 8 to 12 people on our caseload at any point in time. However, some people needed more treatment than others. Some people had more diagnoses than others, or harder to treat diagnoses than others. So the clinician would spend more time, and treatment would be more intensive for that person over someone else who didn't have as many co-occurring issues, for example. Is that just? Well, yeah. Each person is receiving the best treatment possible. We're trying to figure out what is it that we need to do that's in the best interest of this particular person. And nobody is starting from the same place. Everybody presents with different symptoms and different problems. Which option leads me to act as the sort of person I want to be? And this is one of those virtue ethics kind of questions. You're not always going to be able to choose the one that is in line with your virtues. Hopefully, in whatever agency you're in or in private practice, 99.9% of the time, you will be able to choose the option that feels best in your head, heart, and gut. But as we talked about on the last slide, there are some times where you're not doing what you would ideally do, but there are other factors at play. C stands for consult with trusted colleagues, legal advisors, supervisors, the actual research, and yourself. Once you have the data, once you've evaluated the benefits and drawbacks, then talk to other professionals and say, this is what I'm faced with. What options do you see, or what would you do in this situation? Obviously, legal, you call the attorney and say, are there any legal ramifications? Your supervisors are going to be able to inform you about organizational policies and procedures, and theoretically, they sort of represent the organization as a stakeholder, so they can see the organization's perspective. Go on PubMed or wherever you get your peer-reviewed research and look and find out, is there research base to whatever's going on? And then consult with yourself. What is it that in your head, heart, and gut feels like the best option at this point in time? D stands for decide on a course of action. How can your decision be implemented with the greatest care and attention to the concerns of all stakeholders? So you're going to do this, and it's going to affect everybody involved, directly or indirectly. So how is it that you can best implement this plan? And finally, evaluate the outcome. How did your decision turn out, and what have you learned from that specific situation? What would you do differently? What would you do the same? How can you file this away so when a similar situation comes up in the future, you've got some data? Counseling skills development is another area that we need to be conscious of. When you have an illness, do you want a physician who hasn't been trained on new techniques or even reviewed the research since they graduated medical school? I wouldn't. Our understanding of people, development, the brain, and the causes of mental illness is still in its infancy. So skills development helps us avoid providing subpar treatment, helps us become more aware. For example, 20 years ago, dialectical behavior therapy didn't exist, or it definitely wasn't mainstream. So if you graduated college back when I did, and you hadn't looked at any of the research, you might not even be familiar with dialectical behavior therapy or acceptance and commitment therapy or EMDR, all of which have really come to the forefront in the past, 15, 20 years. Skills development helps us ensure we are providing the best possible care and allows us to keep our promise of providing the best possible care. So all of this, avoid providing subpar treatment, that's non-malfeasance. Providing the best possible care, that's beneficence. And keeping our promise of providing the best possible care is fidelity and justice. Not all skills development comes in the form of continuing education or professional development courses. Quite honestly, we really aren't required to get that much ongoing professional development training compared to the volumes of research that are coming out in any given year. It's important to stay up to date. So how do you fit it in? Find a mentor to work under. Somebody, like me, or hopefully you have a mentor in your area who really loves staying in tune with the research, and you can work underneath them and they can teach you as you go, so you're not having to go do all the research and learn the skills and everything. Get task-focused supervision. If you typically work with people with eating disorders, for example, then continue to get supervision from people who are on the leading edge of eating disorders treatment. Self-supervise. Review your charts. If you can get permission, videotape your sessions and review them. Make sure that you're being effective. If you notice, for example, that when you're watching one of your videos that, hey, I missed these 3 opportunities to enhance motivation, okay, well, that's going to help you develop your skills. You may not be learning a new skill, but you are becoming more competent at the skills that you already have. Read journal articles. Go to PubMed, and you can just look online, Google PubMed, and it will come up. And these are your peer-reviewed journal articles. When you review a journal article, if you're not one of those people who is super statistics oriented, who likes to look at the numerical values and the charts and all that stuff, that's fine. Ultimately, the nitty-gritty is in the abstract and the discussion. Now, you can get a lot more if you read the stuff in between, but for the average clinician, the abstract and the discussion, or the introduction and the discussion, provides you more than enough information to enhance your skills. And if you need more than that, then you can consult an expert. Clinical guidelines. These are published best practices. They're out there. They're free for the taking. Why in the world are you not using them? Why in the world are you not aware of them? Or if you are, kudos. SAMHSA has what they call treatment improvement protocols, and they are free. You can download the PDFs, and they're big treatment improvement protocols. They're generally a couple of 100 pages. The American Psychiatric Association, American Psychological Association, and the American Counseling Association all have best practice guidelines or clinical guidelines on their website. NICE is a sort of like our SAMHSA that's based out of the UK. COPE is an organization that's dedicated specifically to improving perinatal treatment. Origin is based in in Australia, and social work policy, I believe, is based in US. But these are all different perspectives on how to treat things like eating disorders and bipolar disorder and addiction. And it can be very fascinating. I think it's fascinating to look at the different approaches that are used by the different fields, by the different professions to address the very same issues. You can also go to resource websites or watch videos. There are some, and you need to be careful about which ones you watch to make sure that they're providing you accurate peer-reviewed information. But there are some channels, for example, on YouTube. SAMHSA even has a channel on YouTube that provides evidence-based information. So for people who don't really like reading a lot, they're more auditory learners, videos can be a great place to get that information. And webinars and conferences. That's a lot of times we go to webinars and conferences because that helps us meet our CEU requirements. But whatever gets us there, because they are going to provide us some evidence-based information. In terms of ongoing supervision, whether it's our initial supervision or supervision we're getting even though we've been in the field 5, 10, 15 years, it helps us become more self-aware or stay self-aware. Identify areas for early intervention, like burnout, and become accountable for our own skill development. And the image I have here is the Johari window. There's that one quadrant. It's information that we know about ourselves and others know about us. Our competence, our skills, our strengths. You know, that's out there for everybody to know. And then the blind self. It's information about you that you don't know, but others do know. So you may think that you're super competent in treating this particular disorder, and your colleagues and your supervisors may be like, think you're a little bit more confident than you are competent. Supervision can be helpful there. If you're working with an expert in EMDR or dialectical behavior therapy, the other people can help alert you to your blind spots. Dialectical behavior therapy's consultation groups, that's one of the main things that they do, is help clinicians remain vigilant of their blind spots when working with their particular caseload. The hidden self is information about you that you know, but others don't know. And that's that part that you haven't shared with your supervisor, for example, imposter phenomenon. Or maybe that you are starting to get burned out, but you don't want to tell anybody. And the unknown self is information that nobody knows. But in supervision, as you process things, just like in counseling, as you process things, some of this information will come out. Some of these windows will be open. Now remember, supervision is not counseling. So a supervisor is going to help you identify how your particular issues or beliefs or whatever are influencing your work with clients. A counselor will help you process those things. How do you fit in ongoing supervision? It can be difficult, especially if you are in a organization that has really high demands for billable hours. Self-supervision, that's the first thing. It's super easy because you don't have to have another supervisor. You don't have to arrange a meeting. Video or audio tape yourself periodically and review it. Look at it with a critical eye and say, why did I ask this question? Or why didn't I ask this question at this particular time? And also look in those same, for that same person, look at the case progress. Look at your progress notes to see, are the people on my caseload continually progressing, or does everybody seem to just kind of be floundering? If they're floundering, that's what we might call a clue that something may be going on that is impairing your effectiveness. Or if you're having a lot of people drop out against medical advice, that might be a clue. You can have colleague meetings. Maybe you can meet with the people that you work with and you have lunch once a week at the facility, so you still have confidentiality, but then you can discuss open cases and protect health information, of course. Peer reviews of videos and charts using a rubric. I like statistics, I like structure, so I love rubrics. However, peer review is really helpful because you can, with a release of information, provide a peer a videotape and a chart on a particular person that you're working with, and that peer can go through and use that rubric to score both the video and the chart progress, which gives you some pretty objective feedback about, are things going well, what your quality is. Staff meeting brown bags are a little bit different than colleague meetings. This again might be a lunch where everybody gets together once a month, for example. But in a brown bag, only one person presents a case, but it's a deep dive into a particular case. So if you started at your facility, maybe you suddenly started seeing a lot more people who are addicted to methamphetamine. You may have a brown bag on methamphetamine treatment and evaluate a particular client or a couple of particular client cases for what is working in those particular situations and why, and what the research currently says about effective treatment of methamphetamine addiction. You can get supervision at work from your supervisor. That's supposed to be happening anyway. And it's important, if you need supervision, that you are able to get it. You are able to schedule it in and it doesn't get put off or rescheduled or minimized or, hey, walk with me and we can talk. That's not supervision. You can also get supervision from an independent supervisor. Some people believe that it is an ethical imperative to pay it forward and provide a certain amount of supervision pro bono to other people in the field. That's wonderful. Other people will charge, and it can get expensive. So that's not always an option for clinicians, but these are all different ways that you can get ongoing supervision, and you can combine them. Maybe you do self-supervision 2 out of every 3 months, and on the 3rd month, once a quarter, you get together with a bunch of your colleagues and each person staffs one case. There are a lot of different options. Now, the next issue that we're going to talk about, or the last issue we're going to talk about, is self-care and burnout prevention. Burnout is so common in a lot of organizations, but especially in human services, because we're seeing people often on some of the worst days of their lives. There are at least 14 characteristics of burnout work environments, and we need to reflect on what can we do to protect ourselves from these things and what can be done at the organizational level to address them. Now, my favorite one, and I don't remember where I found this acronym, but my favorite one is from TLC to TNC. We got into this field so we could provide tender loving care. We could provide help, hope, and empowerment to people. But a lot of times we get into situations where the focus turns away from the quality of care of the person and the outcomes and focuses more on our billable hours, how many people we're seeing, and just crisis management. That's exhausting. And that's also not what you went to college to do. So it can sap your enthusiasm really quickly when you feel like you're constantly just trying to herd feral cats. If there's little boundary between work and home, that also contributes to burnout prevention. And let me go back up to TLC to TNC. I don't have any particular gold nugget answers for these. You're going to have to look at your particular organization. Many organizations set their billable hours at a rate that they feel they need in order to keep the doors open. So the question is, and I'm going to talk about it in a minute in the advice from the trenches, how can you work smarter? And what can you do in order to minimize the crises? At the residential treatment center that I worked at, one of the things that my staff struggled with was, since it was residential, the clinicians were there and the clients were always there. So whenever there was a crisis, which was pretty much constant because they were in the first 30 days of recovery, they were in the clinician's office and the clinicians couldn't get their basic documentation and work done. We got together and we brainstormed, and ultimately we identified a counselor on duty. And we had 5 counselors, which worked out really well. And each clinician had a day of the week that they were the counselor on duty. So their door would stay open in the afternoon from 12 to 4. Everybody else was able to close their doors from 12 to 4 and do paperwork or do their individual sessions and not be consumed with trying to put out fires and handle crises. So the counselor on duty was the one that would be in charge of handling the crises. And there were a lot of positive ramifications from this. You know, not everybody wanted to go to the person who was the counselor on duty that day. They wanted to see their therapist. Well, okay, you're going to get to see your therapist tomorrow morning at 8 a.m. when you have caseload group. So the counselor on duty would help them develop distress tolerance skills or figure out how they were going to make it until caseload group the next morning if they did not want to process it with the counselor on duty. So it encouraged them to start learning to do some better problem solving and manage distress. And it also, staff was better able to meet their other requirements, including their individual sessions. Many organizations and many people in practice, private practice, have little boundary between work and home, and that can be devastating. Even if you're in private practice, it's important that you're able to set a boundary between your work and your home so you don't end up bringing work home with you and it doesn't end up overshadowing the things that you want to do, the things that are important outside of work. How do you do that? Answering services, rotating on calls, having clear options for people outside of your normal work hours so you're not constantly getting called in for this crisis and that crisis. Many times, and in many cities that I've lived in over my 20 some odd years of practice, private practitioners will get together and they will form a coalition, they will form a group, whatever you want to call it, where each one agrees to take a week of on-call in a quarter. So you get 12 clinicians together, then one person is on call for 1 week, 4 times a year. And that makes it much more manageable. Then the other clinicians are able to focus on their family and the rest of their life on the weeks that they're not on call. So that can be helpful. Not everybody loves that option, but it is one option that I've seen work and work quite well. It's also important if you work for an agency to be able to set boundaries between work and home, to be able to say, okay, when I go home, I'm not checking my email. When I go home, then somebody else needs to be responsive to what's going on. In most cases, in organizations, healthy organizations, that's not a problem. So it is important to recognize where that boundary is and who's imposing or removing that boundary. Is it the organization or is it you? Do you feel like, well, nobody else can do as good of a job as I can? Do you feel paternalistic, like it's your responsibility to be there every time one of your clients has a problem? And it's important to look at, again, all of the factors that are going into it. Would it be ideal if you could be that responsive? Well, maybe. You could argue that one way or another, but let's say yes. Okay, But if you do that, then that's going to take a lot of time and energy away from the other things that are important in your life. It's going to start wearing you down, and ultimately likely will lead to burnout and disenfranchisement and all kinds of other things. So is it more important to respond to every single call every single time yourself, or is it better to have referral options and extenders, if you will, so you can set a boundary between work and home? Rapid, unpredictable change is also another cause of burnout. And this can be changing personnel. All of a sudden, there's a new department head, and they've decided that, guess what? I'm going to just change how this whole department runs. Oh my gosh. That can be terrifying and exhausting and maddening all at the same time. Goals may change. And this is one of the things that I frequently hear when I do presentations at organizations on staff retention and burnout, that a lot of times they feel like the goals that they're supposed to meet are on roller skates. They're constantly moving. It's important that the goals stay relatively stable. So the goals that a person has when they do their annual performance review stay stable until the next annual performance review. Maybe they will need to be updated the next year, but you don't want goals and objectives and expectations changing throughout the year and on a quarterly basis. Destructive communication also causes burnout. If communication is always finger pointing and blaming, then it often contributes to burnout because people feel unsupported. Authoritarian leadership in which staff has absolutely no say in what happens can also lead to burnout because you feel like you've got no control. And I've learned from being at all levels of management or all levels in an organization that a lot of times line staff may have a much clearer picture of what's going on and what might help to improve the current issues than C-level executives. Now, C-level executives obviously are more in tune to the budget and some of those other technical things. But it's important that the two of them can come together where staff actually has input and can say, these are where we're having problems. Here's where we're having problems. And upper management can say, okay, this is where we're having problems. Now, how can we create mutually agreeable solutions? A defensive attitude among staff or supervisors also creates burnout because then nobody feels safe asking questions, making mistakes, pointing out where there might be problems. It's just keep quiet, otherwise you're going to get your head bit off. Double standards, where there's different policies and procedures, bias in application for management and employees. And it's important to recognize if you see that where management gets to do one thing and they get away with it, but staff is not able to, that creates a disharmony at the very least within the organization. So addressing double standards and making sure that people are held to the same standards. I've talked before about my first boss who, he was always very prim and proper. From the moment I started working for him, he was a vice president. He eventually promoted to executive vice president. But it's important to recognize that no matter what his title was, no matter how many years of experience he had, if something needed to be done on the unit, he would do it if that had to happen. The most common thing was urine screenings, because sometimes we would be at a point where the only staff on duty were biologically female, and we had somebody who was biologically male who needed to be urine screened. So Richard would just go in there and do it, 3-piece suit and all. And he was willing to do that. He wasn't too good for it. And he recognized that it was important to model that everybody needs to pitch in and be held to the same expectations of doing what needs to be done. Unsolved grievances also contribute to burnout. If you have a problem and you don't have any way to resolve that problem, you just sit there and stew on it and feel miserable and your resentment grows, obviously that's a problem. Or if the only mechanism to resolve it is adversarial, it's an us versus them. I'm going to go to human resources and tell on you, and then we're going to have this sit down and we're going to figure out who they believe. Nobody likes to be in that situation either. So it's important to have policies and procedures for handling problems. A lot of times grievances may come about because somebody doesn't really understand the impact of a particular policy, or because somebody doesn't realize the impact of something they do on another employee or another client. It's really important to be able to objectively look at these things. And my boss always used to say, the same one who would do the urine drops, whenever there's a grievance, it's not a us versus them, it's a we. What did we do to create this? Because whenever you point a finger, there's your thumb and your index finger are pointing out, but you've got 3 fingers pointing back to you. Both parties had a part in this. Emotionally troubled personnel and low morale can also contribute to burnout, because people who are depressed, exhausted, traumatized, miserable are going to be much less productive and much less effective at what they do. Exposure to secondary trauma or working with clients and having your prior trauma triggered can also contribute to exhaustion and burnout prevention. It's important that your agency has mechanisms like employee assistance programs, so people who do have mental health issues or are experiencing secondary or re-triggered trauma have somewhere that they can go in order to get help. Staffing shortages leading to overtime and exhaustion. Unfortunately, this is all too common. And it's important to, as a line staff, to be open with supervisors about what you can and cannot do in order to provide quality, ethical treatment. It's also important to recognize as a supervisor the impact of staffing shortages and caseload changes on people that you're supervising and provide as much support as possible. Repetitive, boring work, like doing 6 assessments in a day, can also contribute to burnout because each assessment starts to blend into the last one. So there may be job sharing opportunities where somebody can do assessments in the morning and individuals in the afternoon. Deficient training, rapidly inundating people with new equipment and operational standards without sufficient transition. And this is true with hardware, like electronic medical records, as well as approaches. There was one organization that I did some consulting for that decided one day that all of their staff needed to be trained and competent in motivational interviewing, trauma-informed care, and dialectical behavior therapy in the next 6 months, while concurrently maintaining a full caseload. That ain't even doable. There's just no way. Procedures like double booking or bad electronic health records that don't allow people to work effectively or efficiently, and then criticizing workers for not being productive, also contribute to burnout. And I've worked on some of those bad electronic health records that what would have taken you an hour to write out by hand takes 3 hours to do in the computer because there's so many different screens and windows to click around, and then if you get lost, you have to back up and you lose stuff. It's just a nightmare. So it is really important for leadership, management, when they create procedures to evaluate it from a user standpoint. You know, if I'm coming into this as a user who's never worked with this before, How effective is it? Electronic medical record, perfect example. I went into this training on this electronic medical record we were adopting as an agency. It was already a done deal. And I'm pretty computer savvy. And I went into the training, and after about 6 hours of the first day, it was a 4-day training, all day, 4 days, just to learn the electronic medical record. After about 6 hours the first day, we were dismissed on a break, and I went over to my boss's office, and I'm like, Richard, I can see why all of my staff is struggling with this, and we're actually losing money. We're having to pay back things because there's so many mistakes. I can see why, because this system is impossible. And he looked at me kind of incredulously, but he showed up the next day, and he sat in the training for the first half of the next day. And at lunchtime, he pulled me aside and he said, wow, I had no idea how absolutely miserably impossible this was. So it was important to point that out, but senior management had not looked at it with fresh eyes to see what it would be like for somebody who hadn't actually taken part in the creation and development of it. So advice from the trenches: eliminate, delegate, prioritize, and simplify. Eliminate things that you don't have to do. If there are things that you can delegate to somebody else, great. Prioritize whatever's left on your list that day. Now, I am structured. I like doing daily to-do lists and then prioritizing. And then simplify. I had a staff person who worked for me for many years, and she used to write some of the most beautiful chart notes and comprehensive summaries, but they were dissertations. And ultimately, I had to break it down to her that this is beautiful work. And if we had all the time in the world, I would say, go for it. This is great. However, you are staying 2 hours after your shift every day to try to get your documentation done because you're putting too much into it. So we talked about ways she could simplify her documentation and still provide quality documentation, but be able to work it into her work day and not end up working 10 hours a day. Practice what you preach. If you're telling the people that you're working with to be mindful, practice mindfulness. If you're telling them to practice work-life and balance and boundaries, then demonstrate that. If you have to call in sick because your kid is sick, or you have to take a day off because you're sick, do that. Don't come in sick and get everybody else sick in order to see all of your clients and disrupt that whole work-life balance and boundaries. What does that say? What does that communicate to your clients? Yes, you're there for them, but it also communicates that you should go to work even if you are not up to it, even if you're too sick to actually do a good job. Recreation, assertiveness, good sleep, and nutrition are also important. These are foundational skills for helping people stay healthy. We need to model them for our clients. Work smarter. Do progress notes while you are in individual. The last 10 minutes of the session, after the first 50 minutes, the last 10 minutes of the session, do the progress notes with the person. Review, what did we talk about today? What progress did you make that we talked about, and have them paraphrase everything that they did. So they're hearing themselves state the progress that they've made. That reinforces it in their mind. And then what are you going to be doing between now and next session? Write it all down. Then have them sign it and you sign it. 80% of your progress note is done at that point. If you've got an electronic medical record, then most of them will allow you to scan in a document and attach it to the file. And then you can do your little part of the notes later, but it only takes 5 or 10 minutes to fill in the mental status exam and any subjective information you want to put in. Same basic thing for group notes. Group notes often aren't nearly as detailed, but having everybody fill out a handout in group that identifies how they're feeling, if there's anything pressing that they need to talk to their counselor about, and what they got out of group that day. Each one of those can be scanned in and attached to the client's file, and then you have less to do in terms of finishing up your notes. Have resource linkages check sheets available. If you're giving most people the resources for housing and urban development and ways to get prescriptions filled on patient assistance programs and the number to this clinic and that clinic, if you're regularly giving out the same numbers, make a resource sheet that you can give to people so you don't have to write it down or remember it every time. Identify repetitive data and create check sheets. If there's something that you have to do all of the time, create check sheets so you're not having to longhand write everything out. And for integrated summaries, this seems to be a bugaboo for a lot of people. For integrated summaries, use a template. What exactly needs to be in this, some people call it the comprehensive summary, at the end of the assessment. For newer counselors and older counselors alike, remember that the two major factors in creating change are your rapport with the person you're working with and helping them feel empowered to make change, helping them feel like they can survive, like they can move forward. The individual techniques are often less important than people's ability to feel safe and empowered to move forward. When you start feeling burned out or exhausted, identify sources of distress and address them with your supervisor and develop a plan to mitigate them. Work from a strengths-based, recovery-oriented perspective. Instead of trying to reinvent the wheel with every person, build on what works. What has helped you deal with these symptoms at least a little bit until now? Let's build on that. Recognize people's expertise on themselves and elicit their input. Most people have an idea about what would help them feel better or what is contributing to their distress. So instead of trying to guess it and act like the all-knowing person, ask them. They're living in their own skin. They know what's worked and they know what they hope will work. And then set realistic, time-limited, episodic goals. A lot of times people expect too much, or they want somebody to enter treatment and stay in treatment until they're 100% in remission. And that may not be realistic. So what is a realistic time-limited goal? What can you accomplish in 8 to 10 weeks? And then at the end of 8 to 10 weeks, if they are ready and still want to continue going, you can reassess. But setting those realistic, time-limited, episodic goals helps everybody have a sense of success and accomplishment in, predetermined periods of time instead of waiting for a year or 2 years until they're in, quote, full remission. Remember the stages of readiness for change to avoid getting discouraged. This was one of the mistakes I made in my first practicum. I was in a substance abuse treatment facility and people would come in, they go to detox, they come over to our side, and I would want them to go from walking out of detox to being in the maintenance stage of recovery in 30 days. And my supervisor had to break it down for me that wasn't realistic. If they came in and they were in the action stage of change, that's great. It doesn't mean that in 30 days they're going to move all the way to maintenance. We want to help them start moving. So setting smaller, realistic goals based on their readiness for change. If they're coming over and they're involuntary and they're still in pre-contemplation, but the judge says they have to be there, okay, well, you're certainly not going to move them over to maintenance in 30 days. The best you might be able to do, probably, is move them from pre-contemplation to contemplation. I don't have a problem to All right, maybe you're right. Maybe there is something to this. Talk with your supervisor to balance your caseload. Not all people require the same amount of energy. If you're working with multiple people on your caseload who have trauma and personality disorder symptoms and substance abuse issues, that's far different than working with somebody who has major depressive disorder. And I don't want to minimize major depressive disorder, but the intensity of the symptoms in the people that you're dealing with who tend to have personality disorders are often much more intense and require much more hands-on or aggressive intervention. Aggressive's not the right word, but you get the point. They require a lot more therapist time and clinical techniques in order to improve. So talking to your supervisor or whoever is assigning the caseloads. When I would have people who had high needs clients, they would have 8 people on their caseload, and other people that had clients that didn't have quite as much of a high needs ranking or whatever, they would have up to 12 people on their caseload. And finally, you can just kind of back it off to, if you are struggling with your energy, with your attitude, with your performance, with burnout, what would you tell your clients to do if they were feeling that way? And see if it fits for you. Clinicians have an ethical imperative to do more than no harm. We must also advocate for research and improved accessibility to services and advanced knowledge and practice in the mental health field. With good self-care and decent time management, you can do a lot to work towards preventing burnout and have the energy and time to improve your clinical skills and engage in additional supervision.